Welcome to the webinar, Pancreatic Cancer-Navigating the Journey. This is proudly presented by Cancer Council Victoria and the Pancare Foundation. My name is Amber Callart from Cancer Council Victoria and I will be your host this evening. Our event will be recorded and made available on the Cancer Council Victoria and Pancare websites within the next week. You may wish to view it again or recommend it to others. Before we begin, we would like to acknowledge the traditional owners of the lands we are meeting on today. We also pay our respects to their elders past and present and to all Aboriginal people participating today. Tonight's webinar will run for an hour and a half. The first section of the webinar will consist of presentations from our expert panellists and a panel discussion. For those of you who have not participated in a webinar before, you do not need to do anything during this time. Sit back and enjoy the presentations. You may like to have a pen and paper ready to make some notes or jot down questions that you can ask later in the night. Towards the end of our session, we will have our live Q&A segment with questions and answers. At this time, those attending the webinar can post a question to the panel using the question and answer function in the webinar software. During the question and answer time, the presenters will offer live responses to any questions that you may ask. If you have any connection problems during the webinar, please call the numbers on your screen, quoting the meeting number provided. During the webinar, some of the presentations will have links to resources or relevant websites. These links are not live in the webinar software that you're using. And what I mean by that is you cannot click on them. We will provide all of the links and a list of useful resources when we email to let you know the recording is available on our website. This document of useful resources will also be available from our website. So the aim of this webinar was really about bringing together a panel of experts with extensive experience in pancreatic cancer to assist in managing some of the physical symptoms as well as emotional and practical needs of patients and their carers undergoing this journey. We hope to alleviate some of the stress and anxiety which can be common for people with a cancer diagnosis by providing evidence-based information, but more importantly, by getting our speakers to offer practical strategies from their personal experiences, which can help people to feel more supported, informed, and able to cope. So there's an overwhelming need for this webinar, and we've seen that we've got 240 registrants for tonight's event, and this includes 32 patients that are either currently undergoing treatment or who have finished treatment. We've also got 120 health professionals and almost 50 people who are friends, families or carers of someone with cancer. Now, I'd just like to take this opportunity to draw our viewers' attention to the Cancer What to Expect guides. The Victorian Department of Health and Human Services commissioned the Cancer Council Victoria to develop these guides for 19 different tumour streams. These resources have been translated into 7 languages, which are available online. These guides help patients and their carers make sense of what should happen during their cancer journey. They can also help with what questions patients should ask their health professionals to make sure that they receive the best possible care at every step. And there is a What to Expect guide for pancreatic cancer. So please have a look at the link after this webinar. So now, without further ado, I'd like to introduce our first speaker. Graham Wells is a lawyer with Social Security rights in Victoria and was diagnosed with pancreatic cancer in February 2015. Since 2007, Graham has been affected by several different cancers, including brain, lung and liver cancer. He will reflect on his own journey and provide others with advice for coping with cancer. Thank you, Graham.
Thank you, and a big hello to everybody that's here this evening. Essentially, I think I'm very, very lucky for a whole lot of reasons, and we'll talk about this as we go. Well, I guess I get to talk about it, and you can ask some questions later if you've got the inclination. Back in 2007, when I first began my cancer journey, I was really quite shocked. And the first person who mentioned to me that there was something serious was a radiology nurse at one of these scanning centres, who said afterwards, "Graham, you might like to come into the kitchen and have a cup of tea." And I was quite surprised, because that's not how any other nurses I've come across behave. Normally it's very clinical and you're in and out very quickly. And you're told to go and see your GP maybe in a week's time and get the results. But her response was, "You need to see your GP quickly," which gave me something to think about, and I wasn't quite sure why. And then it all came home once I met with the GP and explained what was going on. So it's was then a bit of a roller coaster. I'm not going to spend a lot of time talking about that time, because the focus of this evening isn't brain tumours, rather it's pancreatic cancer. So after surgery, after radiotherapy in 2012, thank you, and I found myself a couple of years ago, actually I'll just briefly talk about the diagnosis. You can see the tumour down here, a big white mass at the bottom left-hand side. It's pretty big, and if I go down to the next slide, you can see the scarring. The irony with a brain tumour, it looks quite serious, but in reality it may well be quite serious too, but I've been lucky, so I'm here to talk about it, and it hasn't affected me in many ways. But there's not a lot of feeling in your head, whereas in your abdomen there are a lot of nerves, and so you really know about it afterwards if you've had a Whipple surgery. But with brain surgery, all you've got is a bit of a headache for a while, and people keep offering you painkillers that you don't really need. So coming forward to 2012, actually, in fact, I'll go one more slide further. I got up one morning, I was taking my son to school. I was getting ready to take him to school. And then I was over on the floor in pain as a result of some very acute pain above the appendix area, close to where my heart was. And it turned out it was localised around my spleen, which is if you know where your left-hand rib cage is, in that general area, just underneath it. And apparently, after spending some time in the Alfred, and eventually it was confirmed there were some lesions growing on my pancreas, but no one knew what sort. And this meant going through and getting some further procedures done. I think one was a endoscope, which is going in from the mouth down. The other one is another sort of scope going from another end. And anyway, they confirmed that there were some problems there, but it wasn't bowel cancer and it wasn't anything else, but there was something wrong with the pancreas. It turned out that the bottom part of my pancreas had a thing called atrophied, or wasn't working properly, but no one's been able to explain to me what that means, because there's still some function and it's not something that can really be measured. However, the lesions were on the head of the pancreas, and the question was, what were they? And after a bit of soul searching and questioning, it seemed more likely than not that they were a secondary tumour from the primary site, which had been in my brain. So this type of tumour, hemangiopericytoma, resembled a meningioma, which is a relatively benign tumour, but the hemangiopericytoma was a lot more aggressive. So it tended to reappear after about 7 years, and like clockwork, after 2007, 2012, there it was. So all the literature was correct. So all those doom and gloom stories I saw on the internet, some of it was right, but a lot was wrong actually, but that's another story. Eventually I spoke to an excellent expert pancreatic nurse who said, make sure that if you're going to get a Whipple done, it's done by someone who does lots of these things. And so, thanks, which one is that? We're up to another slide. And I went and found someone who did a lot of these, because the first person I saw about this said I could be dead in 3 months. Now that was clearly quite wrong, and maybe they had a poor bedside manner, but when someone gives you a very bad set of news, then it can shock you, and it certainly shocked me. And so I was sort of gutted by that, and then went seeking further opinions, and then sought out Pancare and realised that they gave patients a lot of support. And so I asked, well, what's the best way of dealing with this? And this particular nurse said to me, after receiving several emails and phone calls and so on, that I needed to find someone who did a lot of Whipples. And so I asked a few people about it and ended up with a surgeon who works out of the Austin, and he did the work for me. And I think he's very, very active in Pancare, so I won't say who he is at this stage because I don't want to sway people either way, but, you know, find a surgeon who really knows what they're doing, who does a lot of these. All surgeons are very good because it's what they do, and they put in a huge amount of time into their area of practice. And so, but for you, it's important to work with someone you can get along with, or that you're impressed by, and most of all, that you trust and listen to. So I'll go that bit further, and the next one is here, I think. And this next slide talks about preparation, and I can answer some more of these questions a bit later. But preparation is fundamentally important, and one of the success stories, I think, or one of the things that has led to my level of success in getting over cancer or coping with cancer is being both mentally and physically fit. And I guess part of that is having a good diet, and someone else is going to talk to you about that tonight. But also, for me, a lot of that was cycling and swimming and doing some meditation and being able to just to clear my head and not worry about things a lot and just let my body get on and do what it's naturally going to do, which is fight whatever is interrupting things and do what it can. And so that might sound a bit far-fetched, but for me it worked really well, is being able to just let my body get on with things and not to panic and worry too much. I opted to go to the Austin, and mainly because there was a whole collection of experts there, and this is something that they did really, really well. I'm not saying other hospitals aren't expert, it's just that for me it worked well going to the Austin. And they were fantastic in talking to me and helping me get ready for this coming Whipple surgery. To the extent, when I first had brain surgery, I went in and I was admitted to a hospital, and on the trolley going into the operation, someone asked me to sign a release form for the anaesthetics and sort of explained it as I was sort of going in. That's not how things work nowadays, thankfully. And in the Austin, there's a pre-admission clinic that I went to, and I was told by the anaesthetist that I had excellent cardiac prospects, which sort of meant that because of my fitness, they were pretty comfortable about a long period of surgery. And Whipple surgery is long. It's maybe 5, 7 or more hours. So, you do need to have, or should have, a level of fitness in terms of your preparation. Okay, the next slide's post-op, and I'll sort of go to it now, and you can sort of see me propped up in bed in a semi-conscious state. You're under a lot of painkillers. I had a block which was put into my spine, and that sort of stopped a lot of pain. And when it finished, I was offered other strong painkillers, one of which was a thing called ketamine, which I want to strongly discourage because it certainly started to give me hallucinations, and I like to think I've got a pretty good set of control on my mind, but anyway, that's what ketamine does, and so it's pretty extreme. And I was in the post-op for about a day before being moved back to the ward, which was a good thing because it brought me back into a sense of, I guess, it's going to sound strange, community, but with everybody else. And one of the things that affects you if you're in hospital for a serious surgery or something is it's very easy to become self-absorbed. And it's important, I think it's important not to get obsessed about your own particular condition and about how hard it might be and so on. And that might sound callous, but it's important for me, it was important for me to look forwards and look about getting out of hospital and getting back to normal. So I'll just keep moving because I'm running out of time already. Walking, any form of exercise, as long as you're not going to overdo it, is really, really good. And the nurses gave me a lot of assistance in getting out of bed because you can imagine you've got a tear right up your chest or from your, right across your abdomen. Any sort of movement you're wanting to minimise because it just sort of starts to hurt and you get a bit paranoid about things. Going home, I was in hospital for about a week, and because we've got stairs at home, I had to walk up and down stairs at hospital to show I could do it. And that was a challenge. It was a challenge, and I was lucky that I was in a fairly supportive environment. But my partner was a bit worried that she wouldn't be able to cope, and there was talk of sending me to a rehab centre at one point, but I refused and went home and found myself getting back into a home routine very quickly, which meant helping with breakfast, helping with lunches and things, and vacuuming and all that sort of stuff. And that was good rehab for me anyway, in terms of exercise. Moving forwards, a bit further down, the key things I found is, and I'm like a bull at a gate, so this is why I'm saying take it slowly, because things do change and it takes a bit of time for your body to get back to normal again. And even now, I don't feel any effect from my Whipple surgery 2 years on, but I'm still not as strong as I used to be. And maybe I need to do a bit more exercise and that I can get that way, but most of my strength has all come back again. But take it slowly, talk to people, and don't be afraid to share your feelings with others, because one of the things in this last slide is not everybody gets over this thing, and who knows, it's still early days for me, but don't let survivor guilt come on or anything like that, because no doubt there are a lot of people out there, and I've got a lot of friends, I've got close friends who died from pancreatic cancer, and the fact that I'm here and they're not is something that I wonder about sometimes. But, you know, when I think about what they would have wanted for me to keep on doing what I'm doing, and certainly that's what I'm trying to do now. So thanks for that. I've passed my time, and I'll hand on to someone else in a moment.
Thanks, Graham. That was a really practical, helpful presentation. The next speaker that we have today is Belinda Lee. Belinda is a consultant medical oncologist at the Northern and Royal Melbourne Hospitals and the Hemstreet Centenary Research Fellow at the Walter and Eliza Hall Institute of Medical Research. Thanks, Belinda.
Thank you. Thank you for giving me this opportunity to speak to you today. I'm going to give you a very brief overview about pancreatic cancer. Unlike other cancers, the projected pancreatic cancer death rate is rising. By the year 2020, it's anticipated that pancreatic cancer will be the second leading cause of cancer-related death. Worldwide, it's estimated that 227,000 people will die from pancreatic cancer. In 2016, it's estimated that 3,230 new cases of pancreatic cancer were diagnosed in Australia. These statistics speak to the enormity of this growing problem. Pancreatic cancer often presents with symptoms such as pain or discomfort in the upper abdomen. You may also present with symptoms of jaundice. This is a yellow discoloration of the skin and the eyes. This is related to the tumour that's blocking the bile duct. Patients may also notice that they have pale stools or dark urine. This is also related to the cancer blocking the bile duct. They may have symptoms of weight loss, change in bowel habit. They can also present with new onset of diabetes, nausea, indigestion, feeling bloated, or fatigue. Along with your symptoms and medical history, several tests may be performed by your doctor to make the diagnosis of pancreatic cancer. These may include imaging such as CT, MRI, and PET scans. Other tests include things called MRCPs and ERCPs. These are performed to see if there is an obstruction. The image in the middle shows a CT scan, which shows the mass in the middle, that's the pancreatic cancer. On the right-hand side are images showing dilation of a duct and obstruction that's noted on the ERCP and MRCP images. Tissue sampling will be undertaken to confirm the diagnosis. This should be performed either by a fine needle aspiration or biopsy that can be performed during endoscopy or laparotomy. You may hear the term staging. Staging describes the size and whether the cancer has spread. This can be described either using numbers, as stage 1, 2, 3, and 4, or in categories, such as early stage and resectable, locally advanced, advanced or metastatic disease. Unfortunately, the majority of pancreatic cancers are detected when they're already locally advanced or have spread. The major challenges that we face in treating pancreatic cancer include defining who is at risk, also developing more effective screening tests to be able to pick this up earlier. We also have relatively ineffective treatments at present, and we need to be able to develop better treatments for these patients. We need to be able to develop treatments that are actually tailored to each patient to be able to say what's effective for each person. Treatment for pancreatic cancer may include surgery, chemotherapy, or radiotherapy, or a combination of these treatments. For early disease, surgery is the most common treatment. This usually is performed through a Whipple's, a distal, or total pancreatectomy. The type of operation that is taken may depend on the position of the cancer within the pancreas. For advanced pancreatic cancer, surgery may not be possible, in which case treatment is aimed at controlling the cancer and relieving symptoms such as pain and digestive problems. Chemotherapy can be used before or after surgery, or with radiotherapy, or by itself. The use of chemotherapy is based on each individual's fitness to receive the treatment safely. There is no upper age limit to treatment with chemotherapy, but patients need to be well enough to receive the treatment. Consideration should be given to other medical conditions and how they will impact how well a patient will tolerate the chemotherapy or increase the risk of side effects from the treatment. Radiotherapy may also be given with chemotherapy or by itself to shrink the cancer or to treat specific problems to relieve symptoms. Patients should be managed by a multidisciplinary team. This means that they may involve a surgeon, an oncologist, a radiation oncologist, a gastroenterologist, an endocrinologist, and a cancer nurse. This should also include allied health professionals such as counselors and dietitians. Symptoms can be managed both in the hospital and outside of the hospital by community palliative care teams. Standard chemotherapy treatments follow consensus evidence guidelines. These are published by groups such as the National Comprehensive Cancer Network, known as the NCCN, ESMO, which stands for the European Society of Medical Oncologists, ASCO, which is the American Society of Clinical Oncologists, as well as local Australian guidelines which are available through EDQ. On the right-hand side, you see a figure that represents the current chemotherapy options in the advanced setting. Over the last 3 years, we have seen publications in 3 strongly positive trials. This includes the Prodigy 4 and Ford 11, which demonstrated the benefit of FOLFIRINOX over single-agent gemcitabine. Gemcitabine was previously the standard of care treatment option. This was then followed on by the MPAC study that showed better outcomes with combination gemcitabine and Abraxane over single-agent gemcitabine. More recently, we've had the Napoli-1 study. This has shown benefit of a new drug called the liposomal NRNT combination, and this is possibly used in the second-line therapy option. This new treatment has been approved in the United States, but is awaiting approval in Australia. Although small incremental gains have been seen with newer combinations like FOLFIRINOX, the median survival in patients with metastatic disease is still limited to 12 months. This highlights the urgent need for a greater understanding of this devastating condition and that we need greater resources to help develop novel therapies. And I'd like to take a few minutes to give you some insight into some of the research that is being done in pancreatic cancer in Victoria. At the Walter and Eliza Hall Institute of Medical Research, we're developing a pancreatic cancer initiative that encompasses research examining the role of inflammation and novel therapeutics in pancreatic cancer. We're also developing new screening tools with blood-based biomarkers and real-time drug testing with organoids. The Purple Translational Registry is an initiative that links cancer centres across Australia to help us to understand the difference between patient groups, to identify how best to treat patients, and also to help us to enable faster and more efficient clinical research, ultimately aiming at improving survival. We'll also be working with the Upper GI Cancer Registry, which is focused on quality assurance, at improving hospital processes and improving patient experience. Another very promising area of research is circulating tumor DNA. This is the potential to allow cancer screening and monitoring of treatment effectiveness through a routine blood test that can be taken at diagnosis, after surgery, or during your follow-up. There will be a study anticipated to commence in September this year. Further details about the study can be available on the website that is listed. This information should be available in the next few months. Another very exciting project that has already commenced enrolment at the Royal Melbourne Hospital is the Organoid Project. This study will develop mini pancreatic organs at the size of a grain of sand, to which we can determine drug sensitivity for each individual patient. Combining this information with each tumour's mutations will give doctors real answers within weeks and help us to personalise treatments and match a patient and which drugs will work for them. I'd like to end off by thanking you for your support. Pancreatic cancer is a devastating disease, and I hope that today's presentation has helped answer some of your questions and highlight the work that has been done to fight against it.
Thank you very much for providing the medical perspective for us, Belinda. So moving on to another Belinda. Belinda Steer is a senior clinical dietitian with over 10 years experience working with patients who have cancers of the upper gastrointestinal tract, including pancreatic cancer. She's passionate about improving the lives of cancer patients and works at achieving this on a daily basis. Thanks, Belinda.
Thanks, Amber, and once again, thanks for the opportunity to present today. So pancreatic cancer itself, as well as the treatments that are used to treat it, can cause many different symptoms and side effects, and many of these can affect your ability to eat and drink adequately. Many of these symptoms and side effects that you see here on this diagram can occur with many different diagnoses, such as loss of appetite, nausea, taste changes, and bowel changes. However, some of these are more specifically related to pancreatic cancer, such as diabetes and malabsorption. The symptoms and side effects of any cancer and any cancer treatment can vary a lot from person to person. I see many people in my day-to-day practice that have the exact same diagnosis on paper and are undergoing the same treatment, yet present with very different symptoms and therefore need really different advice. So this list is not an exhaustive list of the symptoms that people can experience. It's just a start and perhaps some of the most common that we'll discuss today. One of the biggest issues with many of the symptoms and side effects that you may experience is that when they're not controlled or managed, they'll often lead to weight loss. And although many people see this as beneficial, in the setting of a cancer diagnosis, this is not the case, regardless of what your starting weight is, and this is often what I have to start my story with patients. Weight loss in this setting leads to weakness and fatigue, which may limit your ability to participate in any of your usual daily activities and also participate in family events. It can also lead to increased side effects from treatment, which affects your ability to tolerate your treatment, and therefore it can even affect your treatment course. Ultimately, weight loss is not a good outcome and will likely result in a reduced quality of life, something that I work hard at optimising every day with my patients. So with all that in mind, let's look at some of these symptoms that are commonly experienced by people who have pancreatic cancer and how we can help to manage them with their diet. Firstly, let's look at loss of appetite. This is really very common and a difficult symptom to overcome, as there is no magic pill to fix it, although I really wish there was. A few important points when it comes to loss of appetite is remember to try and eat things that you enjoy, because usually this will mean that you eat a lot more. There's no need to force yourself to eat things that you don't like, even if your sister tells you to. We can always find an alternative that you do like and that will provide the same benefits. And remember, eating's meant to be enjoyable. Also try to make the most of what you're eating by choosing nourishing, high energy and high protein foods that you enjoy. This means that it's great if you eat lots of foods such as avocados, oils, nuts, dairy products, eggs, fish, meat, chicken. Try to choose foods that are these types of foods, so foods that are lower in energy or lower in protein. Or if you really feel like a lower energy food, try something such as fresh fruit with custard or yogurt added to increase the nourishment that you're getting. And try to make the most of when you feel hungry, or if that never happens, when you feel most like eating. For many people, this is first thing in the morning when they haven't eaten for many hours. Take advantage of this time and eat as much as possible. Have a 3-course breakfast if you like. Or forget about traditional breakfast foods and have your main meal in the morning. It doesn't matter, it's really about making the most of the good times. And finally, it's important that you try to eat lots of small meals throughout the day, aiming to eat every 2 or 3 hours rather than just 3 large meals. Eating this way usually means that you'll eat a lot more by the end of the day. I tell my patients it's like a full-time job, which really it is, but it's well worth the reward. Next, let's look at nausea. Like loss of appetite, it is quite common, especially if you're having chemotherapy. Many of the strategies that I mentioned for loss of appetite help with nausea too, such as eating every few hours, making the most of when you do feel like eating, and eating foods that you enjoy. But along with these, there's a couple of more tips. The first and most important one isn't even diet related. It's take your anti-nausea medication strictly. I'm forever telling people that you really need to take them sooner rather than later, because once the nausea is started, it really is more difficult to control. And there's nothing we can do with diet that works as well as your medications. So please listen to your healthcare team, including your dietitians that tell you to take them. But along with this, diet can help. In particular, it's really important, despite how you're feeling, that you don't skip meals or snacks and you eat often. When you get an empty stomach, nausea will get worse, and it can be really hard to work out whether you feel nauseous or actually you're hungry. So actually keeping something in your stomach will help you feel better and minimise the nausea, so please try to keep eating. Try dry or salty snacks, such as dry crackers or toast with Vegemite or cheese. Also, cold foods or room temperature foods and foods that don't have strong odours are generally better tolerated. And try to stay away from cooking smells, so it's a good excuse to stay out of the kitchen. And finally, trying to have some ginger in some form can help with nausea. Things such as ginger ale or ginger beer, ginger tea, or even ginger-flavoured lollies can sometimes be helpful. Here's how a patient used food to help deal with his nausea. He said, at times during chemo, I'm unable to tolerate dairy products, meats, good nutritious foods due to nausea or vomiting. So we make up fresh fruit smoothies with a few scoops of powdered supplements to ensure I get as much nourishment as possible. So you can see he's still trying to have nourishing things and not skipping the meals or snacks, just modifying how he feels. Next, we'll look at taste changes. This is another side effect that's often experienced when you're having chemotherapy. Taste changes can be different for everyone. For example, some people say everything just tastes bleh. Some people say that it tastes like I've been licking coins, and others say that everything tastes like cardboard. Everyone is different. But really, the strategies that you use may be similar, yet they may be quite different as well. So if a food tastes bland, try adding extra flavours such as herbs, lemon, lime, ginger, garlic, etc. If it tastes bitter, eat fresh fruits or suck on hard lollies. Eat your food with plastic and not metal utensils, and drink out of a glass or a plastic cup. If your food's too sweet, add things to reduce the sweetness. Try lemon juice or coffee granules, and try to avoid foods that don't have added sugar. Make sure you keep your mouth nice and clean by cleaning your teeth and rinsing your mouth out regularly. And finally, continue to try different things. You may find that foods that you didn't previously like now actually taste really good, so be experimental. Bowel changes is something else that can affect people with pancreatic cancer. It's never fun to talk about, but as health professionals we talk about it all the time, so please don't worry. Some people may experience constipation. This is more often than not related to medications or their treatment, and usually they require laxatives or aperients to help resolve this, and there's very little that you can do with diet. In saying that, it is still important that you drink enough and you do try to increase your fibre intake and be as active as possible, but make sure you speak to your healthcare team for advice. On the other hand, we have diarrhoea. This too can be caused by many things. It may be the cancer, it may be the treatment, medications or infections. So if you're experiencing it, please talk to your team. But before you do that, make sure you take a moment to have a look at it. Yes, have a look at it. I know it's not something any of us like to do, but it's really important. Think about what does it look like? What colour is it? Does it sink or does it float? Is it really smelly or is it just normal smelling? These are really important things to think about and potentially questions that your healthcare team will ask when you go to tell them about it. When it comes to diarrhoea and diet, it's most important that you talk to your team, but if you need to do something from a diet point of view in the meantime, make sure you drink enough to replace the fluid that you're losing, and rather than have more fibre, perhaps reduce the fibre that's in your diet and avoid those really fatty, greasy and high sugar foods. Diabetes, as has been mentioned, is a common side effect of pancreatic cancer, and that's because it's related to the function of the pancreas being affected by the cancer itself or its treatment. One of the key roles of the pancreas is to produce insulin, which is what controls our blood sugar levels to ensure they're maintained at an acceptable level. When the pancreas is affected, it may not produce enough insulin, and therefore you can get an increase in your blood sugar levels. When they're really high, you can feel unwell and contribute to your weight loss. And if this is the case, you need medications to help control them. Diet does play a really important role in controlling your blood sugar levels. However, in the setting of pancreatic cancer, we do not put the same dietary restrictions in place as we would with someone who had diabetes without pancreatic cancer. So yes, you should avoid really high sugar foods that give you not much else, such as lollies or jelly, but include some of those higher foods such as cakes and chocolates and desserts. It's okay. The rest of the nutrition that's in them will actually lower the effect that they have on your sugars, and it's more important that we maintain the weight. So following a diabetic diet can be quite problematic when you have cancer, and as one of our patients experienced, because I'm a diabetic, I get put on a diabetic every time I get admitted to hospital. My insulin's been worked out on eating a normal diet to allow me to maintain my weight, and I always have to request a visit from the dietitian to get this fixed. He really needs to be on a high energy, high protein diet, not a diabetic diet, so please remember that. And finally, to talk about malabsorption, another issue that's often experienced when you have pancreatic cancer. This is because the pancreas, another key role it has, is to produce enzymes that help us digest our food, especially the fats and protein. And when there's a problem with that pancreas and it doesn't function properly, this is one of the things that can happen. The main signs that we can tell this is happening is when you have difficulty maintaining your weight despite eating well, you get abdominal pains and cramping, and you have loose bowels that are pale, smelly, floaty, and are oily. Remember those questions I said to ask? Usually these symptoms alone are enough for us to suspect malabsorption, and we would therefore suggest a trial of pancreatic enzyme replacement therapy, or PERT, given the risks associated are relatively small and the benefits are great. You can see here our patient said that after diagnosis I was put on PERT whilst waiting for my surgery date. I couldn't believe the difference they made to my upset stomach, eating and bowel habits. By the time surgery arrived, most of my symptoms had disappeared, and I even went so far as to tell my surgeon I didn't think I had pancreatic cancer anymore. So we can see that they really can help. The key points that I want you to take home about PERT are that you need to take them whenever you eat something that contains fat or protein. You need to take them at the same time you eat, not 30 minutes before. Please don't crush them or chew them. And remember that they're active for about 45 minutes. So if you're sitting down to a really long meal, spread your dose out. If you're taking them and you notice your symptoms aren't changing, please talk to your healthcare team. It might just be you need an adjustment in your dose. So finally, the important things to remember when it comes to nutrition and pancreatic cancer are try lots of different nourishing foods and different strategies. Everyone's different. Work with your dietitian and your treating team to get the best help that you can. Ask questions, ask for help. And hopefully putting all this together will result in some improvements in your life that you can enjoy yourself with your family and friends and do all the things that you wish to do. Thanks.
Thanks, Belinda. That was a really amazing overview of the symptom management from a dietary perspective. We are now headed to our final speaker, Rebecca Simovides. So Rebecca is a registered nurse who currently works in private practice as well as being a clinical nurse specialist. Rebecca has recently joined the team at Austin Health as a familial pancreatic screening program coordinator, and she's a support nurse for Pancare Foundation, assisting patients and their families diagnosed with pancreatic cancer and other upper GI cancers. Thanks, Rebecca.
Thanks, Amber. I'm here tonight on behalf of Pancare Foundation to talk to you about the support services that we offer patients and their carers who have been diagnosed with pancreatic cancer. I thought I would initially start about chatting about Pancare Foundation for people who aren't so familiar with us. We're a not-for-profit organisation whose purpose is to increase survival and provide support to people affected by pancreatic and other upper gastrointestinal cancers. We fund vital clinical research around the country with the aim to improve outcomes of people diagnosed with these cancers. To be able to continue to fund these projects, we hold regular fundraising and networking events throughout the year. So I thought I might start chatting about the pancreatic cancer journey and what I typically see in my day-to-day work. I meet patients and their carers at various stages. This might be when they're seeking out second opinions or maybe looking for a medical specialist. Might also range from asking about clinical trials for themselves or even their family, maybe something they've read on the internet to check its validity, or it might also be something about they're going through surgery and want to know a bit more. At Pancare Foundation, we're big advocates for second, third and fourth opinions. I have seen a gentleman come to us as his fifth opinion. With my background in surgical nursing and work within private practice, I will often speak to patients or their carers pre-surgery. These chats can range from a number of queries, but I often find patients or their carers want to basically know what to look out for, and I guess just a bit more education. I also find it's a good opportunity for people to ask questions they might have forgotten to ask in their consultations. Fast forward to seeing patients in hospital post-surgery, I often see people at their most vulnerable. There's no secret that Whipple's is a major surgery, but it's so rewarding to see patients make the journey from post-op day one to seeing them ready for discharge. Talking to patients when they're home and beyond, I'll often get calls of clarification. Is this normal? Is my recovery on track? In addition to what we're already doing, is there anything else we can try? It's not uncommon for me to talk to carers in my work. I find that carers often need as much support as patients on this journey. Carers will not only call about their loved ones, but will often ask about logistical things like travel, accommodations, particularly if they're from the country, what's my follow-up, what scans, etc. I'd probably describe my position best as an extra support system, and as mentioned, it's a good time for patients to ask questions that they might not have been able to ask their specialists. Experiencing cancer is an emotional time for families and their carers, and it's no secret that people need support. Whether you're querying your treatment plan or want to know more about what is available to you, contacting us or the Cancer Council can just help you talk through things and lead you in the right direction. Some people find it hard to talk to family and don't want to upset them, so talking to an impartial party could sometimes be beneficial. Thought I'd also briefly touch on some resources that PanCare and the Cancer Council have implemented. So we're working on a series of guides in both printed and electronic format. We've devised the Pancreatic Cancer Patient Handbook. I think it's a great tool in touching on various stages of the pancreatic cancer journey. It goes into details about what to expect after results or what happens during a Whipple, different treatment options for different tumours, etc. In addition, we're also devising a diet and cancer booklet that I think will be a great tool for patients about different things to try and just bring them up to speed on what's best for their care. Often I'll also refer patients to the Cancer Council and have a look at the website which I think the Cancer Council do really well, the emotional support side of things. And there's also a Living with Cancer program that I have been told by patients that they do find really beneficial. It's a reality, but some people don't like talking about their illnesses as much as others. So on our website, we've also implemented some various online resources. Thought I'd touch base on the community care program. It's a program that helps patients and their family deliver individualised care and therapies. It's not just designed for our country patients, but it's also for anyone that feels they could benefit from this type of extra support. This program can be implemented at various times of your journey, from the point of diagnosis through to recovery and bereavement. We've developed a model of services based on the side effects, things such as fatigue or chemo brain, right through the other spectrum of financial stresses or weak social support. And we've also had an increasingly popular service that we get requests for, which is complementary therapies, where research has shown that it has a positive impact on patients living with cancer. It's not uncommon for us to help with accommodation assistance or travel costs, particularly for our rural patients. I think a big positive about this program is it allows patients to choose services that will assist their needs most. We work on the theory that not everyone needs the same type of support as the next person. I couldn't tell you how many times people from the country or rural areas have told me they just can't find any support systems in or near their hometowns. Here at PanCare Foundation, as well as the Cancer Council, we have various ways that people can help find this information. This can be something as simple as sending emails right through to telephone and online resources. Chatting about rural support. So I'll sort of quickly first chat about telephone support groups. I think it's a great tool, particularly for our rural patients. PanCare Foundation, in conjunction with the Cancer Council of New South Wales, help fund the Pancreatic Cancer Support Group. This is a free professional telephone support group that can be accessed from the comfort of your own home from anywhere in Australia. You can join in whenever you feel well enough or on an ongoing basis. There are different meetings that are held at various times of the month. Another great service is the 1300 for a nurse. This might be someone who is a patient, a carer, or an oncology nurse, and it's a great resource where you can call and devise a plan most suitable to you. We have more information about these on our website, which I'll show you at the end. Probably one of my favourite programs at PanCare is the Patient Support Group. This is a bi-monthly meeting that's held in Ivanhoe in Melbourne, and it's also open to carers. We have patients from the country who have gained access to our meetings via Skype, as making the trip to Melbourne isn't always possible. In saying that, we do have a couple of people who travel quite a distance, which is great to see. The meetings usually run by having a specialist speaker at each meeting, and then it's usually a good chance for people to socialise and catch up. We have a good core group of people who attend most meetings, and it's always great to see new faces. Thought I'd just lastly touch on the familial pancreatic screening program that I help coordinate. It's a national research study at Austin Health in conjunction with the Garvan Institute in Sydney. This screening program supports people whose relatives have been diagnosed with pancreatic cancer. There are various criteria for this project, such as 2 close relatives need to be affected by pancreatic cancer, but more details regarding eligibility can be found on the website, and I'll also leave my email if people would like to get in contact. Thought I would read part of an email that a participant sent to me about how happy and supported she was to be part of the program. This project gives me and my family peace of mind. It's quite daunting to know that 2 close relatives have passed away from pancreatic cancer. But knowing that I'm being proactive with my health is the best feeling. Attending a day procedure once a year for 5 years is a small price to pay. In summarising, I think support services are vital for patients and carers to help with the cancer journey. There are various services available, but with the help of funding, we can make these tools even better and more expansive.
Thanks, Rebecca. So the next part of our evening, we're going to ask each of our presenters a question, and these questions have come from our audience members. So Graham, you're up first. It's a question for you. So Graham, given your experiences, what would your suggestion be to others when they're initially diagnosed with pancreatic cancer?
I think the first thing is there's always going to be shock, so that's normal. If you're really upset and shocked, then look, everybody else is too, so don't think you're alone there. The thing is moving forward and doing something, and my recommendation is not to rush. It's simply not, and look, you might feel like the time's ticking or something like that in terms of what stage your cancer's at, but the best thing is just to take it slowly, to go and get multiple opinions, and then work with something you're comfortable with. And look, as I said at the beginning of my presentation, the best advice I had was find someone who does a lot of these. And I'm not saying it has to be with the Austin, and it doesn't have to be with the Alfred, it doesn't have to be with this or that hospital, but it's finding someone who does this every week, pretty much, because the analogy that was given to me, surgery on pancreas is like sewing up a sponge, and because if it's too tight, it's going to tear, if it's too loose, it's just not going to work. And so given that starting point and realising we're all very, very different, you want someone who's going to adjust to your body's needs very quickly during the surgical process. The other big question is, what is it? And is it this, or is it a lesion, or is it just something else? And sometimes people will elect to go and have a biopsy or a needle or some sort of procedure to confirm that. The advice I had was there was something there, and then when I went and asked my older surgeon, well, what do you think? You know, I'm just not sure. There's all these conflicting opinions out there. I feel fine. I feel really good. And his words were, look, if there's something there, it's highly likely it's going to be a secondary. And if it was me, I'd get it out straight away. And that was the definitive thing for me. And it wasn't until after surgery, when the pathology came back, that it was confirmed it was indeed a secondary hemangiopericytoma, or the type of tumour. So that may well be an unknown. And look, let's say it came back after pathology. Look, Graham, it was nothing. Well, at least the system's correct, and it's giving me the opportunity to go and test that, and then to go and make sure that it's safe. And for me, had I not had surgery to remove my tumour, then I probably wouldn't be here now, because it would have got to the stage where it was becoming inoperable. And the nature of hemangiopericytoma is it's highly vascular, so that means it attaches itself to veins and blood vessels, and the bigger they get, the harder they are to remove without damaging one of those blood vessels. So I think I was quite lucky to catch it in time, or to have it caught in time. So yeah, take it slowly, talk to people. I wouldn't spend a lot of time on the internet because there's a lot of rubbish out there, there's a lot of scary stories. Rather, talk to people who are able to give you an independent opinion that suits you. And certainly that's available at all the public hospitals. So you don't necessarily have to spend a lot of money out of pocket to get that opinion, to find out what suits you. And if you've got any other questions, just feel free to email them later on this evening.
Thanks, Graham. Our next question is for Belinda Lee, a medical oncologist. So Belinda, from your own clinical experience, what do you think are the most difficult aspects of navigating this pancreatic cancer journey? And what suggestions do you provide to your patients which you think provides them with the most comfort?
I think the most difficult aspect of navigating this journey is knowing the nature of pancreatic cancer. I think one thing I need to clarify here is that when you get given the diagnosis of pancreatic cancer, there are different types of pancreatic cancer. And what I'm referring to mostly are the adenocarcinomas, which make up about 95% of pancreatic cancers, because other types of pancreatic cancer, including neuroendocrine tumors, do have a different prognosis. So I just want to be clear about that today. I think that's always a difficult discussion with patients, but I think it's important that we have an open and honest discussion. I think it's important that patients feel comfortable to ask the questions that they need to know, and maybe they're not ready at initial diagnosis to ask those questions, but always be available to them to answer that. The other thing that's important is that they're linked in with, a multidisciplinary team to have those services available to them, to make sure that there are dietitians, that there are cancer care nurses, that there's health care nurses, and community nurses are really important as well. I think these are really important parts of the patient's journey, and if that hasn't been offered to you, then don't be afraid to ask your treating clinician about these other services, because that's going to help you a lot through your journey. I think the other thing to talk about is, for many patients, and also for myself, I'm very passionate about research, and I think that knowing that there is research and studies out there can really help patients. It can open up their treatment options, and also, even if nothing else, it can help them know that they're helping other people. And that's, I think, very comforting to a lot of patients.
Thanks, Belinda. Now, just to our other Belinda. Belinda's your dietitian. You've discussed a lot of the how to manage side effects related to pancreatic cancer, Belinda. Is there any one particular diet for people that have pancreatic cancer?
Yes. The short answer is no. The longer answer is yes, in a roundabout way. So, as I mentioned at the start of my talk, everybody is different, and what they're going through is very different. But there is no magic bullet. There's no magic food out there that we should be eating. And really the key thing is that you eat a variety of nourishing foods and that you maintain your weight. Eating just one type of food or cutting out different food groups is far from ideal, because it means you're missing out on vital nutrients, limiting your ability to maintain your weight. So there is no special diet, if you like. There's no special food that you should be including that will improve your prognosis or improve your outcomes, aside from making sure that you're eating a good variety of nourishing foods and working really hard to maintain your weight.
Thanks, Belinda. And our final question is for Rebecca. Rebecca, what do you recommend to your patients to help them cope with anxiety and their uncertain future?
I think probably first and foremost, I would say people handle stress and anxiety different. What some people consider more stressful, others may not. I think if someone wants to be quite open about everything, a support group is a really good option, whether that be in person or, like I mentioned, with like a telephone support group. Finding people in similar situations can sometimes be quite beneficial to some. I honestly don't think it's a bad option for some people to be in touch with a psychologist. I don't think people should look at it as a sign of weakness or something like that, but more look at it as certain tools that might be able to be given to help in certain scenarios.
Great, thank you. So that actually brings us to almost the end of our presentation, but I just wanted to get a final thought or a key message from each of our panel before we head off. So Graham, could we start with you? What would be a key message or a take-home message that you'd like the audience to take away from this presentation today?
Essentially that you're not alone in this, not to relax, because you're not going to relax if you've got this diagnosis of pancreatic cancer. It's going to be quite the opposite. Certainly, as Rebecca said, if you feel a need to talk, go ahead and do so, because it's important. It's important that you feel that you're supported, because the thing that I think is fairly important is to, after all therapy is done, to help the body to get on with it, to do what it does best. And so whether that's through your diet, whether it's through talking to a psychologist, whether it's talking with your oncologist or talking with your radiotherapist or your surgeon, working out what suits you to make you feel good about getting on with this, to get over it.
Thank you. And Belinda, Lee?
I think my take-home message is that there really is an urgent need for us to have a greater understanding of this devastating condition. So we need to develop greater resources to develop new therapies. And for patients, don't be afraid to ask. There are research projects out there, there are studies, and to be prepared to get involved with that, because that's really what's going to bring us forward in pancreatic cancer and improving outcomes.
Thank you. And Belinda Steer?
My take-home message is really concentrate on choosing nourishing foods and drinks and making eating and drinking the enjoyable experience that it should be. I'd really like you to focus on living to eat rather than eating to live. And if you need help, please yell out.
Thank you. And Rebecca?
Probably let us help you. There are support services available on a variety of different levels. So I think we need to make people more aware of these, and like Grant said, you're not alone. And if you want to chat, there are people on a different levels that can chat.
Thank you. So at this time, we're going to transition from the webinar presentations to the question and answer or the Q&A session. Some of you may choose at this time to end your participation in the webinar, and we thank you for joining us tonight. For all Victorians affected by cancer, the best way to get reliable information and connect with relevant support services is to call Cancer Council on 13 11 20. Calls are answered by cancer nurses with experience in major cancer types. The line is open 9 till 5, Monday to Friday. If anyone calls after hours, the nurses can get back to them ASAP the next business day. Emails are answered within 48 hours. Just to let you know that nurses do not provide individual medical advice, only general information, and all calls and emails are confidential. On behalf of Cancer Council Victoria and Pancare Foundation, we would like to thank you for your participation this evening.